first and foremost, the state of interoperability throughout the countries within the GVHP. And so we did a landscape analysis, and we asked what standards were being used, what the method of data exchange was, the purpose of data exchange, and patient engagement, and how patients were involved in that. We had 14 countries and territories that responded. If folks from other countries wish to participate, see me here at the conference and we can sort that out. And we presented our initial results last September in London. And what we found were, first of all, I think a lot of use of international standards. So a gratifying use, at least in these 14 countries, of international standards. We found a lot of use of HL7, ICD-10, LOINC, and SNOMED. We found there was a fair amount of variation in medications. That's one area where every country, maybe because the names of medicines are different, seems to have gone their own way on that. We found pretty much everybody had some active model of consent. Somehow there was a process to obtain consent in that. And that was the heart of patient engagement. We found a lot of interest in the new emerging FHIR healthcare standards, which is part of the modern RESTful JSON software stack that is used by most computer programmers to build apps on smartphones. We've also developed in our consensus process that there's a lot of use of the IHE standards, a lot of installed use of IHE, so folks including Jürgen, our panelists, are working to help harmonize these standards. I don't know if Graham Grieve is here, but we have a special person in healthcare informatics. Graham Grieve, who designed the original FHIR standard, is here at the conference. So I don't know if I don't see him here in a moment, but if you see Graham Grieve, he's the person who invented this from Australia. So yesterday we worked on what are the next steps to move interoperability forward for all of these great goals. And we identified a couple things, and again, if folks have different inputs, please see me and or other members, and we'll sort things out. But we wanted to have global alignment of standards, so some work, I think, between FHIR and IHE. We also wanted to think about how the ICD-10 and 11 standards sync up with SNOMED. We had a great suggestion to do country-specific localization of standards, right? It's the same way that character sets are localized. We had suggestions on standards by clinical areas, so physiology, diagnoses, lab results, the medications. We talked, in the US, we actually have a listing of all of the available health standards that we're encouraging the US. You can see that at our healthit.gov website. So we're thinking about how that might look on a global basis. And then there's some interesting emerging standards. Finland and Estonia are working on e-prescribing, and we're doing FHIR queries at a population level. So we're going to roll these things out over the next year. So that gives you a sense of the GVHP workstream program on interoperability. We're again very mindful of some of the interesting technologies. ADHAR has been extremely interesting to look at. In the United States, we do not have a national patient identifier. So thinking about that, we have 2 case studies. And so I'm going to turn it over to Hattie Beeson from the Secretary of State in the United Kingdom to present on her work. And then Jürgen.
Is that going to work? I'm afraid I'm a little bit short. Can you all see me? Perfect. It's a great honor to be here in a room full of people who obsess about the technical architecture of healthcare as much as I do. I'm a software engineer by training, and I have experienced a variety of roles around England's National Health Service. And because I've built software for the NHS, I've seen firsthand why we need to move away from disconnected silos to interoperable systems. Standards is how we get there. Let me tell you why we think interoperability standards are important. In 1987, a catastrophic fire destroyed much of King's Cross Underground rail station in London. London Underground had its own firefighting equipment, but the blaze was so bad that the London Fire Brigade were rushed in to help. But when they arrived at the scene, they found that the Underground's hoses didn't fit their water sources. This confusion and delay made it much harder to fight the fire. Lives that could have been saved were lost because essential firefighting equipment wasn't interoperable. It's now recognized at the very highest levels in the NHS that we've got a similar opportunity with our digital health architecture. Patients are still being asked, "Why are you here?" countless times because their medical records don't follow them around the system. A blood test taken in one part of the NHS isn't always valid or visible in another. A couple of years ago, we commissioned a review of information flows in the care sector. One care professional described what happened when care homes and nursing homes aren't able to share records with hospitals. She said, "When we send someone to hospital, we don't hear anything for 3 or 4 days. Then a call comes from the hospital ward. Is the person able to eat? And I say, yes. Have you not fed them? It's been 3 or 4 days. This is missing a massive opportunity to improve patient care. We need our systems to be able to talk to each other because when they don't, people suffer. Getting this right is a top priority for the UK government. So, what does this mean in practice? Well, last autumn, we published our first ever tech vision for the NHS. The purpose of the vision can be summed up in one sentence. We want NHS tech to be more like the technical architecture of the internet. That means open and interoperable, capable of consistent incremental improvement, able and willing to adopt the latest innovation, and part of an international ecosystem. Agreeing and mandating interoperability standards are central to this goal. We need the hose to fit the fire hydrant. Last week, we announced the creation of NHSX, a new joint unit among our central health bodies tasked with driving our tech vision through. It's bringing together the tech policy levers, clinical leadership, powers, and funding that have been scattered across the NHS, concentrating them into one strong team, one accountability structure, and delivery focus around the needs of the user. This will radically simplify the organizational complexity that's conspired against tech transformation in the past. Quite simply, it will mean we can get things done. We want to spread innovation much faster, so that health tech companies that jump through all the hoops to sell into one part of the NHS won't have to repeat the whole process with another hospital up the road. Designing, agreeing, and mandating interoperability standards will be central to NHSX's remit. So, drawing on our tech vision, we will apply the following 4 principles. First, we will base our standards on user needs and use cases. If we're designing the standard around a new digital care pathway, for example, we will go into hospitals and ask patients, clinicians, and their families what data and metrics make most sense to them. We want to be collaborative co-producers rather than assuming we know best. Our standards will be designed and agreed in partnership with clinicians, patient groups, and health tech suppliers, along with international groups like the Global Digital Health Partnership. Second, our standards will be open. All of our standards will be collaboratively agreed and published on the web. We want everyone in the health tech economy to see what our requirements are, so anyone with the skills and know-how can build for the NHS. This is a really important part of leveling the playing field between challengers and incumbents, and this openness should broaden our contribution to the global healthcare economy. We will use mature open standards already in existence, where they meet the needs of our users, and are pleased to be a part of GDHP, where we are all collectively pushing the state of the art. And where we've built something that works well, we want to invite other healthcare systems to reuse our code and standards too. Third, our systems will be modular, not monolithic. We want our systems to be capable of continuous upgrades as new tech develops. We want an evergreen NHS, not a legacy NHS. That means decoupling the different layers of the IT stack, so we can plug in new services without having to rebuild the plumbing each time. And it means mandating interoperability at the point where we purchase from our suppliers. So if the commissioning organization fails to require interop in their contracts, then they don't get the thing they're after. Because ultimately, it should be as easy to switch primary care IT applications, for example, as it is to switch email clients for reading your email. Fourth, we will prescribe the bare minimum. We're not interested in micromanaging every interaction between our suppliers and NHS customers. We know from our experience that we could easily become the bottleneck, a barrier to innovation. We will set a minimum level of standards, consistent with ensuring system-wide quality, security, and interoperability. Within that context, we will let local NHS teams buy whatever they want from whoever they want. We don't really care who builds the new fire hose, as long as it fits the hydrant. And we will use the best off-the-shelf technology where our needs are like everyone else's. We won't be building unnecessary bespoke